بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good afternoon, dear resident. It's really a pleasure and honor to share with you VTE prophylaxis in acutely medical patient. The VTE prophylaxis or prevention is a broad topic, and there are different presentations for surgical patient, orthopedic, obstetrics, and gynae, and neurosurgical. So the focus is going to be in VTE prophylaxis or thromboprophylaxis in hospitalized medical patient. So I will navigate you through my content of the presentation. Will be go for introduction, then we'll talk about the fundabarinics, which is the theme of the presentation, pharmacokinetics and pharmacodynamics, use of fundabarinics and VTE prophylaxis, what's the evidence base behind it, and what are the list of the clinical advantages, and the practicality about fundabarinics, and share with you the most recently published ASH clinical practice guidelines on VTE prophylaxis 2018 and 19. And we'll talk about our experience VTE prophylaxis audit at King Fahd Medical City, this is the most important part, and we'll conclude, by take-home messages. First, the introduction. The topic is about venous thromboembolism. As you are fully aware, venous thromboembolism encompasses deep venous thrombosis and pulmonary embolism. There are two sides of the same coin. Usually we prevent DVT, and subsequently we prevent the disastrous complication of DVT as pulmonary embolism. This is a venogram. This is obsolete, investigation. Nowadays we use only Doppler ultrasound to diagnose DVT. We don't use venogram. This is a BE, which is a massive pulmonary embolism for one patient. Remember, it's very important topic. We have 10 million cases of VTE, about 600 deaths in Europe and United States. That is equivalent for 1,600 deaths per day. And if you translate it to daily mortality, it's about like one death every 1 hour. And really time matters for these cases. Just to know that this is 1 in 4 people die from causes related to blood clot, could be acute MI, stroke, or massive pulmonary embolism. So any vascular cause, and it is the top cardiovascular killer. It's the third cardiovascular killer after acute MI, then stroke, then will be followed by massive BE. And it's the most important point here. It's #1 cause of preventable death in hospitalized patient. And why we focus about hospitalized patient, or because 60% of all venous thromboemboli cases occur during or following hospitalization. So hospital-acquired VTE account for 60%, which is really more than half. And it could be surgical or medical patient, as a broad categories. And why it is more 60%? Why it is more in hospitalized patient? We know that if we compare hospitalized to non-hospitalized patient, about like more than 100 times common in hospitalized patient than the public people or healthy people. So it's very important, like the hospitalization can increase the risk substantially high, about 100%. So that's why it's the leading preventable cause of death among hospitalized patients. 1 out of 10 hospital deaths are attributed to hospital-acquired VTE. So about 10%. So you don't want your patient to be, from that 10%. If we implement thromboprophylaxis, what we will do, we'll prevent asymptomatic DVT. This is the most important. This is a silent disease. It does not always present with leg pain, swelling, hotness, redness, or limping, or difficulty walking. It's a silent. And why we call it silent? Because it has no manifestation, but the first presentation is the complication, which is pulmonary embolism. So a patient might be asymptomatic, no leg pain or anything. He might just have sudden pulmonary embolism that can lead to death. That's why this is, we prevent, so we don't wait for symptoms to treat. So we have to be proactive. So we give prophylaxis to prevent asymptomatic DVT, to prevent symptomatic DVT, to prevent the long-term complication of DVT. We call it post-thrombotic syndrome. Also, we present, pulmonary embolism and the chronic complication of PE. We call it chronic thromboembolic pulmonary hypertension, and we prevent death, which is the most, feared complication. Hospitalized patient at high risk of VTE, and VTE leads to substantial cost, mortality, and morbidity. Morbidity. Very important that if you have hospital-acquired VTE, the cost will be from the extended length of stay. Number one, it will be from ICU hospitalization. Sometimes you have massive PE, require ICU hospitalization. Also from diagnostic, workup like CT, ultrasound. Sometimes you need MRI, and also from the treatment, the anticoagulant therapy. That's why effective, safe, and cost-effective measures to prevent hospital-acquired VTE exist. So we have, plenty of clinical trials, and we have abundance of clinical practice guidelines. Remember, prevention of VTE is a standard of care in all hospitals. So if you deviate from the standard, then you will be, responsible or for any action like you have hospital-acquired VTE. More than 400 RCT prove safety and efficacy of VTE prevention. There is no question or query about it. And we have also numerous guidelines that recommend routine prophylaxis for more than 25 years. And thromboprophylaxis is #1 ranked patient safety in hospitalized patient. So also regarding the SIBAHI, which is the national accreditation body, it is considered one of the essential safety requirements. We call it ESR, and 2 points that you have patient are screened for the risk of developing venous thromboembolism. So this is risk screening. And also patient at risk receive prophylaxis according to current evidence-based practice. There are 2 points I will discuss. So we identify at-risk patient. This is if you have the risk assessed model. The one we are using in the hospital, it's Cabrini risk assessment model, or RAM. Very important to have to identify at-risk patient. This is very important point. We have major gap in this. We don't assess the risk. We don't identify. We don't document. If it is not documented, means not done. So it's very simple. I will show you in the subsequent slide. You just tick the risk factors, age of the patient, if the surgery, for example, duration of the surgery, risk factors, and family history, thrombophilia, etc. So it's very, you don't need to memorize it, just look at it and identify the risk factor and choose it properly. Then very important, counsel at risk patient, like we explained to the patient the importance of VTE prophylaxis, because some patients, they are not aware about the importance of VTE prophylaxis. He just receive injection and he doesn't know what does it mean, what's the importance, so they refuse. So we have to counsel at risk patient. And then the last step, prescribe thromboprophylaxis. Very important, this is, we call it identify at risk, I mean documentation of risk, and counseling at risk patient, and also prescription of thromboprophylaxis, or we call it the process measures. And then we have what we call, this is another important measure, we call it outcome measure, hospital-acquired VTE. Just for your information that we are monitoring hospital-acquired VTE, and I will show you our data about. Now we move to the next, about fondaparinux pharmacokinetics and pharmacodynamics. Remember, fondaparinux may be resident the first time to, some of the junior resident. maybe to hear the first time about fondaparinux, but senior, they have seen me using this drug. We started to use fondaparinux like from 2003 to, 2013, 14. First introduced into formulary as alternative medication for HIT, heparin-induced thrombocytopenia. Then from last year, it was the indication was extended to VTE prophylaxis for hospitalized medical and surgical patients. Maybe residents are not aware about this. So it is approved for VTE prophylaxis like unfractionated heparin, like low liquid heparin, like enoxaparin, and we have another option, fondaparinux. So this is first of its class, and this is highly selective for its target and no risk of pathogen contamination. And remember that the evolution of anticoagulant drugs started, long time ago. The leech, it has saliva. Saliva of the leech, it has what we call librodin, which is one of the direct thrombin inhibitor. This is the first, anticoagulant discovered. This is before Christ, BC. This is long time ago. Then we have this is important landmark or milestone, heparin. Heparin discovered more than 100 years ago. It was discovered, by medical student. Then we have, we call it McLean. Then we have another landmark about 30 years ago, low molecular heparin, discovered about 30 years ago. It's very important point that as the first anticoagulant like heparin and vitamin K antagonist warfarin, they target multiple key proteins in the coagulation cascade. Like for vitamin K antagonist warfarin 27910, here you have antithrombin 10A, 2A with different ratio. Then as we move on, drugs are being aimed to single target. Here we have antithrombin and 10A with different ratio. More here, it is more antithrombin, more 10A inhibition than thrombin, which is 2A. Then as we move on, like what we have 2002, we have fondaparinux. We call it indirect factor 10A inhibitor, which is only inhibiting 10A. This is indirect, because then we have what we call direct. That's why we call it direct oral anticoagulant. Like we have oral direct thrombin inhibitor like dabigatran, then we have oral direct factor 10 inhibitor like apixaban, rivaroxaban, edoxaban, betrixaban. There are many. The pipeline is still. So what's the advantage of that? Drugs are being aimed at single target than in the old drug, they are targeting multiple key protein, the coagulation cascade. More targeted approach that more effective and less bleeding risk. So very important that this has enabled us in the management of, like in the past, we used to hospitalize all venous thromboembolic patient for IV heparin. Then once, after discovery of low molecular heparin, now we are treating patient as outpatient. Also with fondaparinux as well. It is one of the approved treatment for VTE and prophylaxis. So what's unfractionated heparin? The ordinary heparin, what we have it. Ordinary heparin, it is call it unfractionated because the molecular weight is high, about 15,000. Then we have what we call depolymerization or fractionation process. So they will be broken to low molecular heparin about 5,000. Then, so this is biological. These are biological drugs. So they are from porcine origin, from pigs. And also it can be from bovine origin, cows. Then we have, again, what we call, this is the active binding site, pentasaccharide, or like 5 saccharides. So this is fondaparinux, about 1,500. So it is smaller molecular weight. Then we have another 2 drugs. They failed the clinical trials. They are not existing. Idraparinux and this is biotinylated idraparinux. So it's not available. Only this one, fondaparinux. So this is very, smaller molecular weight. That's why it does not cause HIT, because not like anaphylaxis heparin or luminous heparin, so they have what we call polysulfated polysaccharide. It is only 5 saccharides. So what's the differences between the anaphylaxis heparin, luminous heparin, and fondaparin? This is a very important point. Remember, the source is both biological, as I mentioned before. This is synthetic. Molecular weight already 15,000. This is explained before. The target here for fondaparinix 10A, very specific, 10A inhibitor, but it's not direct like what you have oral, what you call direct or anticoagulant. This is indirect through inhibition of antithrombin. Then we have here, this is 2A and 10A for heparin and luminous heparin, but here different. The luminous heparin, it is more 10A about than anaphylaxis heparin. They have, it is 2A more than 10A. Bioavailability is very important. This is 100% available. This is 30% and 90%. Half-life is the shortest heparin. That's why heparin given infusion. And usually, like very important, if patient going to OR, you should hold heparin for minimum 2 hours. Minimum 2 hours to 4 hours. This is very important. This is always in the consultation resident, they'll ask you. So you should be held 2 to 4 hours. And if the patient high bleeding risk, like, the vascular, the endovascular, or I are very cautious, very anxious about the anticoagulation, you can hold it for 4 hours, okay? For enoxaparin, it should be held 12 hours before procedure. For fondaparinix, it should be held about 24 hours. The half-life is the longest half-life, about 17 hours. Renally excreted, so heparin is cleared through hepatic clearance. That's why given in patient with end-stage renal disease or severe insufficiency. But luminous heparin about partially renally excreted as fondaparinix. So both you have to be careful in patient with end-stage, severe renal insufficiency and end-stage renal disease and severe insufficiency less than 30. You should use heparin. The antidote we have for heparin about protamine sulfate, about 100% antidote. For luminous heparin, it's again protamine sulfate. It is partial antidote, 60% reversal. And for fondaparinix, protamine sulfate is not the antidote, but we use generic hemostatic measures like prothrombin complex, concentrate, plasma, etc. So the risk of heparin-induced thrombocytopenia is the highest with anaphylaxis heparin, about less than 5%. With luminous heparin, it's about less than 1%. And this is really some case report, but it's exceedingly rare, even if I would say it's almost zero. That's why we are using in the treatment of HET. So I expanded and elaborated in this table because this is very important. You have to know, because these drugs are commonly used for hospitalized medical patients as well as OPD. So you have to understand the point. So another important point not mentioned here, we do need to monitor fondaparinix. It has a predictable pharmacokinetic and dynamic. I will show it to you later on. Also for luminous heparin, we do need to monitor anti-factor 10A because again it has predictable pharmacokinetic and dynamic. But for heparin, it has unpredictable pharmacokinetics. That's why you need to be monitored through ABTT every 6 hours, and you have to maintain the ABTT in the target. This is a very important point to keep. So what about the fondaparinix sodium? So what you have? For prophylaxis, you have 2.5 milligram. So this is used for VTE prophylaxis and used for acute coronary syndrome. If you are rotating in cardiology, you will find it, okay? And also used for superficial vein thrombophlebitis treatment, SVT. Very important superficial vein thrombophlebitis. It's the only approved drug or recommended by the guidelines. However, we are using others. We are using luminous heparin and using DOACs for superficial vein thrombophlebitis, but this is the most recommended by guidelines for 45 days. Then we have the 7.5. Unfortunately, it is still in the registration process by the Saudi FDA, 7.5. 7.5 milligram for VTE treatment. So easy to give once daily, 7.5. And there are some guidelines. If the patient weight less than 50, you give 5 milligram. If the patient more than 100, you give 10 milligram. So easy, but the average dose about 7.5. So this is the, what I mentioned, this is targeted mechanism of action. So remember, this is the coagulation cascade, just focus here. So you have extrinsic pathway and you have intrinsic pathway. You know, the extrinsic pathway, the tissue factor pathway, like this is factor 7. Here for the intrinsic pathway, factor 8, factor 9, factor 11, 12. So you have here, you know, the convergence of the two pathways lead to the, what we call the activation of factor 10. This is a very key, you know, protein in the coagulation cascade, very important. Factor 10 is the single most important. That's why all the anti-new or anticoagulant, they are targeting factor 10A. So factor 10A, you have inhibition. How fondaparinux inhibit factor 10A? Indirectly, not directly. So what will happen? You have here the antithrombin. So you have fondaparinux bind to antithrombin. After binding, what will happen? It will inhibit factor 10A. So if you inhibit factor 10A, so you'll not be able to convert the prothrombin to thrombin. This is very important. If you don't form or generate thrombin, then you'll not be able to convert fibrinogen to fibrin. That's why if you have the clot, we call fibrin clot. Usually the clot, it is like you have the fibrin in addition to the platelets and RBCs. So this is what we call the fibrin clot. So that's very important. This is, we call it indirect factor 10A inhibitor through antithrombin. What's the pharmacokinetic for this drug? It's very important. Rapid onset of action with significant plasma level, about the Cmax achieved within 25 minutes. The maximum concentration within 25 minutes. So if you inject the drug within 25 minutes, you reach, you know, the Cmax, the maximum concentration. Then it can, as I said, continue up to 36 hours. But the half-life I mentioned for you about 17 hours. This is very important point to me. Half-life 17, but it's about 15 to 18 hours. That's why it's used once daily for all indication, never used BID. So what's used for the fondaparinux and VTE prophylaxis? What's the evidence? So evidence behind it, we have a large clinical trial program with about 60,000 patients. So you have for treatment, you have treatment of VTE, for treatment of acute coronary syndrome, famous, you know, OASIS trials. But we have here about prevention of VTE. So we have all these for major orthopedic surgery, all these trials, abdominal surgery, and we have medical patient Artemis. This is the Artemis trial. So I will gonna discuss with you the Artemis trial of VTE prevention. So they compared fondaparinux with the placebo. So remember this trial conducted about 2002 or 2001. So the patient, they are medical patient, and typically they are elderly, more than 60, and expected to require bed rest for more than 4 days. And they are hospitalized for congestive heart failure, acute respiratory illness, and the presence of chronic lung disease, acute infectious or inflammatory disease. And they followed up them for 32 days. So randomized to placebo and fondaparinux. Remember, this is about 2002. You might ask, oh, how come it's now the standard of care to give VTE prophylaxis? How come it is unethical to just, you know, give them placebo? This is 2002, but nowadays nobody will conduct any study placebo. Usually will compare with other drug. So the fondaparinux, the odds, you know, reduction about the VTE reduction medical patient, placebo, see the incidence about 34 versus 18, and the fondaparinux about with the odds reduction about 50%. 50% less, you know, fondaparinux compared to placebo. And they found reduction in fatal PE, which is very important, 29 to 18, about very significant reduction fatal BE, about 1.5% to here 0%. So a significant B value. Again, also decreased the incidence of DVT, as I mentioned before. Also bleeding for the safety, we want to have effective drug and safe drug. Also, it's safe drug. The bleeding was not significantly higher than the placebo. So if you can see 1% on the Thromboprophylaxis, one patient, major bleeding total here, it is 1. So it is almost, equivalent. And minor bleeding, which is about 11 versus 4, but the most important major bleeding, it is parallel. So how we compare the Artemis with the Artemis trial, which was published 2003, with the other landmark studies. This is very important for enoxaparin Medonix, published 1999, and dalteparin Prevent 2003. So they are, our population, it is like, older. So the elder patient, they are higher risk to get thrombosis, and also they have the same risk factors. And all they found major bleeding during treatment for Medonix, about enoxaparin 1.7, for dalteparin and Prevent 0.5, this is the name of the trials, and for Artemis 0.2. So even it is similar or less bleeding profile compared to, the low molecular heparin, and also very important, it's very similar to placebo. So it is effective and safe drug as well. So we don't have head-to-head clinical trials comparing any of the anticoagulant to each other for VTE, prophylaxis, and acute medical patients. We don't have like comparing Thromboprophylaxis with enoxaparin and dalteparin. We don't have. So all the approved anticoagulant for this indication were compared to placebo. And Thromboprophylaxis is the only anticoagulant that showed significant reduction in fatal BE compared to placebo, among others, approved for the same indication. So what are the clinical practice guidelines? So usually clinical practice guidelines are derived from the clinical or randomized clinical trial, RCTs. So this is for ACCP, this is 2012. So remember that anaphylaxis heparin, BID, what we call low-dose anaphylaxis heparin, or Thromboprophylaxis, it's approved for acutely medical patient, and actually favored over unfractionated heparin. So this is another, guidelines, ESMO guideline. This is European Society of Medical Oncology guidelines for cancer patient, also Thromboprophylaxis of equivalent safety and efficacy in patient with cancer if compared with unfractionated heparin. And very important, cancer patient undergoing major cancer surgery prophylaxis with low molecular heparin, unfractionated heparin, or Thromboprophylaxis is recommended. Now we're talking about what American Society of Hematology guidelines published 2 years ago. This is for VTE prophylaxis, but last week we have most recent publication for VTE treatment. So my focus here about VTE prophylaxis. I discussed with Dr. Amani, we can plan another webinar to discuss VTE, latest update in VTE treatment. So very important when we talk about medical patient, we have to categorize. We say acutely ill medical patient. This is patient hospitalized for a medical illness, our patient. Then we have critically ill patient suffering from immediately life-threatening condition, admitted to an intensive or critical care unit, ICU, CCU. Then we have chronically ill medical patient. This is important. This is were defined as those medical condition who may be cared for in long-term facility, long-term care facility. This is very important. This is a frequent question, encounter in the clinical practice, that patient, chronically ill patient, after hospitalized or after discharge home, should we give them extended VTE prophylaxis or not? We'll see here what the guidelines mention, okay? So very important differentiate. Chronically ill medical patient can be admitted with acute medical illness like UTI or pneumonia or COVID-19, etc. But after discharge and resolution or recovery from the acute medical condition, they will be chronically ill medical patients. So we should not confuse. This is very important terminology we have to start with. So there are about 10 recommendations. I just summarized the most important recommendation. So recommendation 1, 2, 3, an acutely ill medical patient, the American Society of Hematology Guideline panel suggests using unfractionated heparin, low molecular heparin, or fondaparinux rather than no parenteral anticoagulation. And among these anticoagulants, the panel suggests using low molecular heparin or fondaparinux over unfractionated heparin. Why? Because unfractionated heparin, it is twice daily and sometimes 3 times daily. This is number one. And the most important, risk of hit. Risk of hit is high, as we mentioned, about 5%, okay, for these patients. So very important, you have advantage, you know hit. I'm sure you have, experience the patient with hit, how they are catastrophic, okay, and difficult to manage. So recommendation for critically ill medical patient, like this ICU patient, the ASH guideline panel recommends using unfractionated low heparin or over no unfractionated or low heparin. This is important. Then critically ill medical patient, the ASH guideline panel suggests using low heparin over unfractionated, as we mentioned before, because of the risk of hit. Maybe in the ICU here, they did not put fondaparinux because ICU sometimes you need, because the longer half-life fondaparinux ICU patient, you have frequent procedures, central line insertion, intubation. Sometimes you don't need longer drug, longer half-life. That's why I'm just telling you the guideline, why they add drug and why they remove, okay, another indication. Then acutely, recommendation 6, acutely or critically ill medical patient, both like ICU and medical ward, the ASH guideline panel suggests using pharmacological VTE prophylaxis over mechanical. So we know that the most effective is pharmacological more than mechanical. Then recommendation 7, again for regular ward and ICU patient who don't receive pharmacological VTE prophylaxis, the ASH guideline panel suggests using mechanical. Very important. I have seen it many times. Patient, have contraindication for pharmacological prophylaxis, and they did not, replace it with the alternative mechanical. Very important. We have seen hospital-acquired VTE. We have seen morbidity cases because patients were not put on mechanical prophylaxis. It should be like a knee-jerk reflex. So patient contraindication to pharmacological, automatically give mechanical. And already we added in the risk assessment model, if you have in the about precaution contraindication, we added that to use mechanical prophylaxis if you have contraindication. Then recommendation 8 and 9, in acutely or critically ill medical patient, same ICU or regular ward, the ASH guideline panel suggests pharmacological or mechanical VTE prophylaxis alone over combined mechanical and pharmacological. Very important. If you have the risk assessment model, we have option that you can combine pharmacological and mechanical in patient with very high risk of VTE. Here they don't, recommend. They don't recommend, or they, better to use suggest, because recommend mean it is strong. Okay, recommendation. No, this is a weak recommendation. They say suggest pharmacological or mechanical should not be combined. This is based on a clinical trial published by Yasin Arabi from National Guard for ICU patient. They combine mechanical and pharmacological prophylaxis compared to just pharmacological prophylaxis, and they did not add or confer additional benefit. That's why, based on that, still we are using combined for high-risk patients, but this is after that clinical trial. The evidence is not, supporting that. So for recommendation 10, acutely or critical ill ward and ICU patient who are receiving mechanical VTE prophylaxis, the ASH guidelines suggest using pneumatic. So they suggest a pneumatic compression device or graduated compression stocking for VTE prophylaxis. So they don't favor, although we think that and other guideline that pneumatic compression device is more effective than elastic compression stockings, because a pneumatic compression device, it is a mechanical, we call it dynamic mechanical prophylaxis, whereas elastic compression stockings, it is static mechanical prophylaxis. Very important to think about this, dynamic mechanical prophylaxis stimulate the endogenous fibrinolysis. So if you stimulate endogenous fibrinolysis, that's why you prevent clot, in addition to the, stimulating the gastrocnemius muscle, the pump. This is, we call it the venous pump, to prevent stasis. Recommendation 11, in acutely ill hospitalized medical patient, the ASH guideline recommend using lumefantrine over DOACs, because also DOACs now approved by the American Society, not American Society of Hematology, by the American FDA. They approved DOACs for VTE prophylaxis. Here they are saying, and this really makes sense, that lumefantrine is favored or superior to DOACs as a VTE prophylaxis. This is dimension for medical patient. And then recommendation 12, in acutely ill hospitalized medical patient, the ASH guideline banner recommend inpatient VTE prophylaxis with lumefantrine only, rather than inpatient and extended duration outpatient VTE prophylaxis with the DOACs. So important, like acute medical patient, acute ill medical patient, so you use only inpatient VTE prophylaxis, and we should not extend duration as outpatient, but only during hospitalization. They are saying if patients are on a DOAC for other reasons, this recommendation not apply. Like a patient already on DOAC before for under indication like AFib, etc., should be continued. Okay. Then recommendation 13, acutely ill medical patient, the ASH guideline banner recommend inpatient over inpatient plus extended duration outpatient VTE prophylaxis. This is very important, as I mentioned, for ICU and for regular ward. Then a critically ill medical patient, ASH guideline banner recommend inpatient over inpatient plus. So all again for ICU and medical patient should be only during hospitalization, not extended. Now we are talking about, this is the most important point for residents to understand. In chronically ill medical patient, including nursing home patient, ASH guideline banner suggests not using VTE prophylaxis compared with using any VTE prophylaxis. So only during hospitalization, should not be extended after discharge. Very important that this, a remark that if a patient status changes to acute, other recommendation would apply. What we find our medical patient, most of, vast majority of our patient admitted to the medical ward, they are chronically ill medical patient, multiple comorbidity. After we discharge them, after we treat the acute medical condition and discharge home, should not extend VTE prophylaxis. This is the general recommendation. This is, however, there are case-by-case basis. We extend the prophylaxis for some chronically ill medical patient if they have previous history of VTE, family history of VTE, additional risk factor, patient, there is a central catheter, etc. So this recommendation is not like universal or a blanket. No, so we are case-by-case basis. We are extending VTE prophylaxis for chronically ill patient. This is very important. But the role is not to use it. But for some cases, I will extend prophylaxis for chronic medical patient. Then in medical, this is another recommendation, important. Patient coming to the clinic, like patient UTI, and he's, diagnosed in the ER and discharged, and he's coming to the clinic. Should we give prophylaxis for this patient? So medical outpatient with minor provoking factor for VTE, for example, immobility, minor injury, illness, infection, ASH guideline banner suggests not using VTE prophylaxis. So we should not use VTE prophylaxis for ambulatory outpatient. We should not use it for chronically ill medical patient after discharge home. Now, what about recommendation for long distance traveler? When we say long distance traveler, more than 6 to 8 hours. So in people who are at substantially increased VTE risk, like patients who have recent surgery, history of VTE, like previous, family history of VTE, personal or family history of VTE, postpartum, woman, active malignancy, or more than 2 risk factors, like including combination of the above with hormone replacement therapy. This is very important. Hormone replacement therapy or combined oral contraceptive pills, this is very common to be used, obesity or pregnancy. And in home, lumoxifarine or graduate compression stocking is not feasible. So what we use for this patient, we use lumoxifarine. I did not add this recommendation. So for this high-risk patient, we use lumoxifarine. If the patient is, as they mentioned, that is not, we use lumoxifarine or graduated compression stockings, but the patient, if cannot afford, here they said these options, lumoxifarine and elastic compression stocking, not feasible, patient due to resource constraints or other, contraindication, then they suggest to use aspirin. So aspirin, yes, it is one of the medication to use to prevent VTE for long distance traveler. This is important after lumoxifarine and graduated elastic compression stocking. So what are the list of clinical and practical advantages? So now, again, for fondaparinux compared to heparines and lumoxifarine. So we said fondaparinux, it's chemical synthesis. This is animal origin, could be bovine or porcine. Here, this is single pure chemical entity like pentasaccharide. This is very important. Heparine, especially unfractionated complex heterogeneous polysaccharide, and there is polysulfated heterogeneous polysaccharide. That's why this is the sulfate is the one triggering the hit. It binds to numerous proteins and endothelium. That's why what will happen, it binds to protein like platelet factor 4 protein. This is a platelet. That's why it will trigger hit. That's why what we send the antibody, it is anti-platelet factor 4 IgG or IgM. That's why it binds. This fondaparinux does not bind to platelet factor 4. So that's why it does not trigger hit. Also does not bind to endothelium. If you bind to endothelium, it will lead to rapid metabolism. This is typically with heparin. That's why half-life is short. For fondaparinux, no endothelium or endothelial binding. Very important also, no interaction fondaparinux with cells like osteoblast, so it does not cause osteoporosis, but anafractional heparin, lumoxifarine, it can cause osteoporosis. Also does not bind monocytes and platelet, because binding monocyte and platelet trigger, the heparin-induced thrombocytopenia or pro-inflammatory cytokines, etc. Then this is simple mechanism of action through inhibiting factor 10, indirectly through antithrombin. Here there's complex mechanism of action through different different coagulation factors. So fondaparinux has no clinically significant risk of hit. Is a pure, unique synthetic chemical entity consisting of 5 pentasaccharide, and hit occur about 0.5 to 3 patient treated with anafractional heparin, and less frequent with the lumoxifarine, about 10 times less than unfractionated. And usually, to date, a causal association between treatment with fondaparinux and occurrence of hit has not been established. So use in renally impaired patients. So fondaparinux can be used at the same dose, usual doses, without the need of adjustment for the patient with mild renal impairment, like more than 50. But if you can be used with caution in patients with GFR 30 to 50, and it should be contraindicated in patients with GFR less than 30. It is monitoring easy. Fondaparinux does not routinely require any kind of blood monitoring. So we don't need platelet because it does not cause hit. We don't need a BTT because like unfractionated heparin, we don't need anti-factor 10A level. Fondaparinux does not inactivate thrombin. It's activated factor 2 and has no effects on platelets. So very important, it does not inactivate thrombin. Thrombin or factor 2. That's why if you inactivate thrombin or factor 2, it will lead to as antiplatelet effect. Fondaparinux is given as single once daily dosing for all indication. And moving right now to what are the VTE prophylaxis audit report. This is important. So what's the aim of this audit? This is important for you resident that to improve compliance with the venous thromboembolism prophylaxis guidelines at KFMC for all hospitalized or admitted patients to reach 100% by December 2020. And actually we failed. Yani over the past 7 years, we failed to reach this target because the tools of our success, you are our tools of success. If you don't do it properly, we will not succeed. We failed before, and that's why we are again launching educational campaign about the importance of compliance to VTE prophylaxis, VTE risk assessment, and prophylaxis. So very important to improve compliance of risk screening. We know this is important, VTE risk screening, and improve documentation with regard to the VTE, which will help in assessing the patient correctly, improve the quality of care and patient safety at KFMC. So this is 2016-18, the compliance with completeness. So what I mean, about 100% the patient, 95 to 100%, they are on pharmacoprophylaxis, but the completeness, of the VTE risk assessment form, it is, deficient. There is a major gap, about 54%, 2016, 2018, 49%, and I will show you about 2019 and 20. And this is, remember, this is very important now, the MOH, they have what we call VTE prevention program. And I think this month I will share with you, there is a presentation about the importance of VTE prophylaxis. Going to be 3 presentations, one about VTE prophylaxis medical, one surgical, and one obstetrics and gynecology. And I will be presenting the part VTE prophylaxis in medical patients. Remember this, all these important points that VTE prophylaxis, one of them. This is very important. الجلطات الوريدية, venous thromboemboli. So all these are important points. This is KPI. So this is like now in the dashboard, you have venous thromboembolism. And what target population? This is when we started about 2018 and 2016, about 350 cases, about 51%, about 180 male, and almost 50%, 172 female. The mean age, if you see our patient, about like 50. Our patient is sicker, elder, okay, multiple comorbidity, more have, cancer, different and longer length of stay, and they are obese as well, okay. So mainly medical patient we audited, so that's why really we have to focus on medical, because everywhere they are account for vast majority of patients in all hospital, and they use the drugs. We have lomotibarine is the most common, then we have unfractionated heparin, then we have fondaparinux. This is about long time, and this is like 2016. And a very important timing, it should be used prophylaxis within 24 hours. So this is important. Vast majority of patients that we use within 24 hours. Then we have a patient that within 48 hours, and you have patient within 72 hours, etc. So the standard should be used within 24 hours, should not be delayed. And the best to do it upon admission in the emergency, you start prophylaxis. Otherwise, if you leave it, you will forget. And this is the risk categories. About like we have low risk, about 25%. When we say low risk, mean the patient is not at risk, should not receive prophylaxis. Then we have about all these category, we call it at risk, whether it is moderate, high, or highest, they should be on prophylaxis. So our patient really at higher risk to get VTE, and this is the completeness already I showed you, about 54% completed. What are the missing? What we say inappropriately completed. Risk scoring, most common, is not done. Very important. Risk scoring not done, not checked, or risk scoring incorrect, either overscored or underscored. If the scoring is the risk factor selected, then the prophylaxis is not selected, or prophylaxis selected but inappropriate. So all these we are auditing. That's why we not only just fill the form and that's it. That's why we have to be meticulous to identify the gap. We have to be honest with ourselves. If you fill it, you have to fill it with conscious. You know, you have to be conscientious. Because if you remember, this patient could be your relative, it could be your family member, okay? So do it right, so it will be reflected on patient safety. This is a top patient safety priority. What the finding? We have 100% of patients have VTE form in place, but however, only 50% of the form was appropriately completed, and risk scoring either overscored, underscored, contraindication, precaution. We don't have any reason documented if prophylaxis is not indicated. And important, if you have contraindication to pharmacoprophylaxis, we have seen no mechanical prophylaxis prescribed and documented. So this is an important point to mention. This is the policy revised. This is the form, you have seen it. We have two forms, adult inpatient, and we have pregnancy. This is for antenatal, postnatal, and this is for cross KFMC. This is the updated one. Always we update to close the gaps and close any ambiguity, because there was confusion and step 3, the prophylaxis section. So we remove it and we update it. And this is now, just to let you know, important. Now it's about after 1 month, we'll move to electronic. So you will not see the manual one. The manual one, again, the same principle. So you have to first risk stratify the patient or identify the risk factor. We call it mark risk factor. This is number 1. Then you have to, after you mark the risk, then you have the risk score. Is it low risk, moderate, high? Then you have to look for the contraindication precaution. The same principle, you will have it in electronic. It will, you know, the launching of EPIC going to be on January, I think January 5 or, but January you will transition to electronic, the EPIC one. So the same, this is the EPIC, Cabrini Risk Assessment, VTE assessment code. So this is the same risk factor. So you have to just click take the risk factor. This is the same, the age. It's even, you know, the many studies, they found out electronic VTE prophylaxis module is more effective than manual. It's gonna close the gap for the risk VTE risk assessment. Hopefully we'll have 100% compliance. Then you have the patient Cabrini risk score. So from 1 to 0, the same. Then you choose low risk VTE or increased risk VTE or critically ill without bleed. So this is very important. EPIC project. Also we have Cortex. Already we Cortex we tried for 1 day and failed the electronic module. Maybe people not aware about it. We worked a lot on it, but only just a few hours after implementing or launching Cortex, the electronic VTE risk assessment, it failed after 1 hour. So now you don't see it. This is the one. This is, I told you up to 2018. Let's see up to now 2019-20. And you can see this is the VTE screening. I mean the form completeness, all excellent, it's present. Then you have the VTE screening on admission per hospital. So we are categorizing Women's Specialized Hospital, Cancer Center, main hospital, cardiac center, etc., neuroscience. So where is the gap? So this is good. The gap here, the completeness of the VTE form. So this is the 3rd quarter 2019, 4th quarter, then 1st quarter, and last one, 2nd quarter to 2020, 60%. So we are, you know, declining. And if you just break it down, you will see main hospital 55%. This is mainly, as we said, the majority of main hospital, medical patients 75. Then you have 25% surgical. So this is a really major gap here. And the other gap is Women's Specialized Hospital. So we can do better. Remember this one, especially the DIB, it was, I think that the junior, the new academic year, the resident, they were not maybe trained well for VTE risk assessment. This is, again, we have what we call rescreening. So what does mean rescreening? Mean there is a change of the condition, like a patient admitted as deemed to be a low risk, no VTE prophylaxis, but the patient developed acute medical, issue during hospitalization or fall, etc. So the patient condition change, and also a patient like for surgical patient for OR. So that's why it need to be what we call VTE rescreening. So the form has to be refilled. Again, there is a major gap we can see in the VTE rescreening. What about prophylaxis? I know prophylaxis, sometimes you just write prophylaxis before you fill the form, which is not good. So the prophylaxis is good, 97, 98. But the most important documentation, this is not Dr.sheef request. This is the SIBAHI, this is the national accreditation body. It is one of the essential safety requirements. They need documentation of the VTE risk assessment, and they need VTE prophylaxis. So both, they go hand in hand. You should not just write prophylaxis and leave the form, empty or filled inappropriately. Then we have the last key performance indicator, hospital-acquired VTE. So the international standard that accepted one about three or less to have, per 1,000. This is the incidence. 3 new cases per 1,000. So you can see here our data for 2020 from January, the high is 7.2, 6.2, 4, 5. So last one is about 4.2. How we calculate it? Very important. The formula, all hospital acquired VTE cases. For example, let's say this is let's say take this one January. So 13 about total number of admissions that January about 1,800. Then time 1,000. Then we calculate. This is we get it 3.6. This is hospital acquired VTE per 1,000 admission. So that's important KPI. We are here. We have 4.2. We are above. Remember, they compare KFMC with other secondary care hospital, tertiary. Remember, our hospital is the largest. One of the largest tertiary care hospital. We have more complex cases. Also, we have here the COVID. COVID pandemic affected also this one. The incidence of hospital-acquired VTE. What we mean hospital-acquired VTE? There is case definition criteria. Patient developed VTE after hospitalization, 72 hours. And or after discharge, 90 days, up to 3 months. If the patient developed VTE, DVT, or BE within 3 months after discharge, we label it as hospital-acquired VTE. And from hospitalization, after 48 to 72 hours. So just to sum up our journey, okay, we started, what we call VTE multidisciplinary team in 2011. It was Dr. Abdesam and me at that time. We with Dr. Al-Adham from ICU to initiate the VTE prophylaxis committee. Then we have moved, VTE prophylaxis committee that in charge of the risk assessment model, of the policy update and awareness campaigns, conferences, etc. So we have standardization. Now we have the standard VTE risk assessment model. This is very important to use. And we have VTE prophylaxis pathways. We have VTE prophylaxis CBP. This is the recently updated. Then we move to the knowledge. Knowledge by what we are doing right now, continuous indication, awareness days for public, symposia conferences for healthcare professionals, hands-on training workshop. We will have hands-on training workshop for all trainees across KFMC. And one of them will be internal medicine. It will be different than this presentation. It will be cases. Then we'll ask you what's the risk assessment score for this patient, and what will be the prophylaxis, not didactic presentation. Then the implementation, we have pathway, guidelines, policy, quality improvement, we have project, the performance measurement, the VTE clinical audit. This is what I showed you, the VTE clinical audit. We do it having compliance quarterly, like 4 times per year, and hospital-acquired VTE reporting and cross-sectional studies annual. And then we'll go for quality and patient safety improvement. So the conclusion, data from this audit shows that we are quite good at prescribing prophylaxis, 95 to 100% for hospitalized patients, but less good at documenting the VTE risk. about 50%. And it's very bad that main hospital about is like the least, after the worst after women's specialist hospital. The second, audit that I showed you before, this is the one I showed you audit February 2018. It was beginning of academic year. Maybe this is the effect, okay? That's the brand new resident, so they are not familiar with the risk assessment model. That's why hopefully we repeat the audit. We will see in the next quarter, there will be remarkable improvement. So reporting of all hospital acquired VTE to KFMC VTE committee. What we are doing, any hospital acquired VTE, report it to our committee, and we conduct root cause analysis. Then we will, formulate strategic improvement plan and action plans. And many VTE prevention efforts fail because of lack of standardized guidance integrated during the episode of care, or due to risk assessed model either offer no guidance or too complicated. That's why the manual, we think it is really complicated. That's why what we do, the trainees, they bypass completing the form. So they just write the prescription, the prophylaxis, but they don't fill the form. So that's why I think the new electronic module will provide closure to this documentation gap, inshallah. And so recommendation and actions that will structure education awareness program for all staff, including VTE prophylaxis and the orientation, and have academic days will serve to enhance the skills and competences of the staff. And electronic VTE module will ensure improved compliance. And also we'll have online competency VTE prophylaxis module for healthcare provider, like what we do for hand hygiene or infection control. So there will be one. And VTE screening and prophylaxis as a key patient safety priority, ongoing compliance monitoring from clinical audit, KFMC VTE committee review, hospital acquired VTE cases, and continuous improvement of staff knowledge and skills will help us achieve and sustain this patient outcome. Thank you very much. We see education material about protect yourself from blood clot to educate patient about, we will distribute again. This is about last year. And remember, prevention of VTE is a key patient safety priority, and help us, please help us to make our hospital a VTE-free hospital. Thank you very much. The floor is open for questions.
Thank you so much.
Yes.
So thank you so much, Dr. Mohammed. We have questions in the chat section. If you kindly could open it, or you want me to read you?
Sure, where is the chat? Okay.
So starting with the question of Munira.
Yes, okay, Munira. So you start from up, or okay?
Yeah.
Munira, yes, okay. Hey.
So she's asking about Caprini score.
Isn't Caprini for patient going to surgery? No, it's Caprini risk assessment model is validated for medical and surgical patient. Initially, it was validated for surgical patient, now used for medical, and is used across now in Saudi Arabia, MOH, and King Faisal, National Guard, military. What we are using, Caprini risk assessment model. There are other models, by the way. In the state, they are using improved model. The state, they use improved model. Also, Europe, they use Bodowa score. So there are many scores. There was, a notion that we will have Caprini risk assessment model for surgical patient and Bodowa score for medical patient. Remember, now we have one risk assessment model, unified one, and we are not doing good. Imagine that you have two scores, okay, that will gonna create confusion. And remember, especially because ICU patient, like ICU patient, oh, is it ICU surgical or ICU medical? So what was the decision from the MOH, because I'm part of the advisory board of the Minister of Health, VTE prevention program, and here to use Cabrini risk assessment, and it's quite good. You know, if you take the elements from the Bodua score or improve, you know, model, and put it in Cabrini, they are all, it's included. In addition, there are points related to surgical patient. So it is very comprehensive. It can cover surgical and medical patient. I hope I answer your question, Dr. Amir, but this is very good question, okay? Next question, we'll ask him at the end of the
Fatma.
Hey, thank you for your presentation, Dr. Sheef. Was wondering if there are any recommendations regarding discharge patient who was on central line during admission and removed immediately before this. No. So central line removed, there is no recommendation to extend VTE prophylaxis. But if the patient discharged with central line, it's deviated from medical patient, oncology patient. Oncology patient, if they were discharged with central line, like, you know, they have for chemotherapy, I forget the name of the catheter they use, okay, Portacath or other, you know, catheters, these patients need to be on prophylaxis. Oncology patient, there are guidance for this. We should extend VTE prophylaxis for cancer patient with central venous catheter. And usually medical patient, we don't, you know, discharge them with central venous catheter, but maybe some patient for home health care or for extended antibiotic, if there is central line, yes, central line, okay, there is no recommendation, telling you my you know, opinion, okay? There is no recommendation to extend VTE prophylaxis for non-cancer patient. But I think, as I told you, chronic medical patient, if, I mean, case-by-case basis, if there is central line, yes, it is advisable to extend VTE prophylaxis for these patients until removal of the central line, because the risk of thrombosis is going to be high. If do you have more questions, they can ask directly, open the mic, okay?
Sir Mohammed, I have two questions, if you allow me. The first question about elderly patients. You already, I think, mentioned this point, but I couldn't really fully get it. So elderly patients expected to be bed confined even after discharge for a long term. So no evidence suggesting continuing the VTE prophylaxis.
Definitely. Yes, thank you. Yeah, that's it. No evidence to suggest or recommend extending VTE prophylaxis for this patient, because they found, you know, there are systematic review. They found the risk of bleeding is outweighing the benefit of VTE prevention. So that's why they are hesitant to give or extend VTE prophylaxis, because you remember these elderly, yes, they are at high risk of thrombosis and they are at high risk of bleeding. Let me just to clarify one point. Remember that when we say medical patient, why they are at high risk for thrombosis? Because of the, number one, not only immobilization, not only due to like confinement to bed. Okay, this is one important, because this is just to like chronically ill patient who are bedbound. Okay, they are at home for, let's say, for years. They are fine. Once they hospitalize or admitted to the ward with a UTI or a pneumonia or whatever, they develop DVT. You might ask yourself why they did not develop VTE at home, and they develop it during hospitalization, because it is multifactorial process. The most important trigger is the inflammation from infection or connective disease or acute MI or stroke. So like COVID, you know, remember 19 patients. So the infection, you know, stimulate the inflammation, the you know, secretion of pro-inflammatory cytokines. You know, these cytokines, it can stimulate, it can trigger the coagulation cascade, activate coagulation cascade, especially tissue factor pathway. So tissue factor pathway, you know, that lead to thrombin formation and clot formation. That's why this patient, we are aggressive to give VTE prophylaxis during their admission with acute medical illness. But once they discharge home and we are sure the infection is treated, they are not anymore receiving, you know, active treatment, so they should not be given prophylaxis. So it is multifactorial. Just to recap again, it is immobilization important. However, other important factor like infection or inflammation or connective disease or inflammatory bowel disease or stroke or acute MI. This is the one that really trigger, the clot. Is it clear, Dr. Mani?
Yes,
And
yes.
this is very important point. I don't want to people to confuse it because this is very important point. It's like a gray zone. And I was asked, I'm telling you a question asked by a resident, excellent question. Why this patient for long time at home not develop DVT and here they develop DVT? This is the reason, because of the infection or inflammation.
Because the situation, doctor, is the same with even paralyzed patients, some neurological patients.
The same.
I saw some of them are on long-term VTE prophylaxis, so that's why. طيب,
This is not good practice. This is not good clinical practice. I've seen patient like paralyzed patient, they discharge them on long-term prophylaxis. You know, they will get the complication, bleeding, osteoporosis. Remember, I told you long tabarine can cause osteoporosis, etc.
Okay.
Or pathological fracture. Yes, Dr. Aman.
Okay, so my second question, Doctor, it's very simple. So just to remind myself and my colleagues, this assessment form is not applicable in COVID positive patients, right? We depend on D-dimer mainly, right?
No, the for COVID-19, there is special, what we call thromboprophylaxis form for hospitalized COVID-19 patient.
Okay.
And it depends on the D-dimer as well. So we put it that to different two aspects. The first aspect that all hospitalized COVID-19 patients should be given VTE prophylaxis, what we call universal strategy. No, all COVID-19, not like a medical patient, you stratify this patient, you risk score them. They are at risk, you give them prophylaxis, or they are not at risk, just you go for ambulation, etc. No, different. COVID-19, universal strategy, all COVID-19, they should be on prophylaxis. But what will be the intensity of thromboprophylaxis based on the dimer? If it is more than one, like for MOH, they will increase from once daily, like 40 to 40 BID. If they are more than for ICU patient, you give half intensity. There are, I don't want to go in details, but this is excellent question. You have to differentiate between COVID-19 patient from, non-COVID acutely ill medical patient.
Okay, excellent. Please, if you have any further questions, this is our chance since Dr.sheef is here with us. إذا عندكم أي أسئلة عن الفورم ال VTE form.
And inshallah, we'll have another presentation about the electronic form and how to use. There will be training for EPIC, about VTE prophylaxis, etc. Just to, important point that feel free, okay, don't hesitate to prescribe, other like fondaparinux. So you have now the option unfractionated heparin, you have enoxaparin, which is a Clexane, and you have fondaparinux. So you can, all of them are approved for VTE prophylaxis. And each one I explained to you the pros and cons, advantages, disadvantages. In addition that the fondaparinux once daily, this risk of hit, so feel free to prescribe it. Widen your experience, okay? So if no more questions.
Dr. Fatma is asking another question. Any recommendation for COVID-19 patients VTE prophylaxis after discharge?
Yes, there is that's why different. We are not mixing up acute medical patient with COVID-19 patient. So what you need to do after discharge, the same what we are doing, Cabrini risk assessment. If the patient is at risk, it should be extended VTE prophylaxis for 14 days with, you can use enoxaparin, or you can use fondaparinux, or you can use DUAC for 14 days. And there is the guidance from ISTH, International Society on Thrombosis and Hemostasis. So although some patient, like last week, we accepted one patient from Abdurrahman Al-Faisal Hospital, Imam Abdurrahman Faisal Hospital, from the ICU, directly accepted here. Is a young patient, about 29-year-old female, type 1 diabetes mellitus, hypothyroidism. and she was hospitalized with COVID-19 to ICU, but did not require intubation or mechanical ventilation. Discharged home. After a few days, she bounced back with massive pulmonary embolism. So massive pulmonary embolism, and she was transferred to our hospital, accepted for catheter-directed thrombolysis. So it was very extensive BE, bilateral saddle pulmonary embolism, and she was thrombolized. So if you go for that patient and risk stratify her, she will not be candidate for extended prophylaxis. You get the point? And she will be only just for inpatient VTE prophylaxis. That's why my advice, be generous with these COVID-19 patients. Just extend their, VTE prophylaxis up to 14 days because the high risk of venous thromboembolism.
Okay, perfect. Thank you so much, Dr. Mohammed. I think we don't have, Muhannad is asking and Jumana as well. Oh, okay, so no questions. Khalas, thank you so much, Dr. Mohammed. We were really glad to have you in our first academic half-day activity. Inshallah, looking forward to having you again. Thank you so much.
You are welcome. It's my pleasure. Okay, thank you for attending.